Hey everyone, and welcome to today's Explainer. Today, we are opening up the clinical toolkit to tackle something you deal with all the time, veterinary antiemetics. Because let's face it, managing emesis in our canine and feline patients, it's not just about giving a quick shot to make the vomiting stop. It's about really mastering the specific neurological and peripheral pathways that are driving that reflex in the first place. So, consider this your ultimate guide to mastering the clinical management of emesis. Let's get started. But before we get into the actual drugs, we have to stop and ask a pretty provocative question. Is your antiemetic helping, or is it actually harming? When a vomiting patient walks through your doors, reaching for just whatever antiemetic is closest on the shelf is a massive risk. Guessing the wrong drug isn't just ineffective, it can be incredibly dangerous for your patient. We absolutely have to match the mechanism to the malady. Okay, let's dive into this. We are building a 5-part toolkit today. We'll start with the broad-spectrum heavyweight, move on to the refractory savior, check out the prokinetic classic, review the older fallbacks, and finally tie up the whole shebang together with a clinical selection quick reference. All right, Section 1, the broad-spectrum heavyweight. And we're talking, of course, about Maropitant citrate. Now, Maropitant was the very first true broad-spectrum veterinary antiemetic, and it literally changed how we practice. But how does it work? Well, it's a neurokinin-1, or NK1 receptor antagonist. Its entire job is to block the binding of substance P, which is a major neurotransmitter involved in vomiting. By blocking substance P, Maropitant shuts down the vomiting reflex centrally, at the emetic center and the chemoreceptor trigger zone, and peripherally, along the vagal efferent nerves. It's like a central switchboard operator just cutting the communication lines that tell the body to vomit. Because it has this dual central and peripheral blockade, its indications are huge. It's our first-line choice for acute undifferentiated vomiting, and it's fantastic for intense inflammatory conditions like parvoviral enteritis and acute pancreatitis. You can even use it for motion sickness at higher oral doses. But hey, major red flag time, you absolutely must avoid giving the injection to puppies under 8 weeks old or the tablets for motion sickness to puppies under 16 weeks due to a severe risk of bone marrow hypoplasia. Also, do not use it if you suspect a GI foreign body or a toxin ingestion where vomiting might actually be necessary for clearance. Oh, and always use caution with hepatic dysfunction since it's heavily metabolized in the liver. So practically speaking, what are you grabbing off the pharmacy shelf? In the veterinary space, you're going to see Indian and imported brands like Maropitant Forte by Vitox, Petomitic by Vico, the imported Cerenia by Zoetis, and Maropitant Forte. It generally comes in a 10 milligram per milliliter injection for sub-Q or IV use, tablets ranging from 16 to 160 milligrams, and we're even starting to see some emerging oral suspensions like Maropitant Plus. Moving right along to Section 2, the refractory savior, Ondansetron. Now, what's really interesting about this one is its precision. Unlike Maropitant's broad substance P blockade, Ondansetron is a heavy hitter because it's a highly selective 5-HT3 receptor antagonist. It specifically targets and blocks serotonin, and it does this peripherally, right on the vagal nerve terminals in the GI tract, as well as centrally in the chemoreceptor trigger zone. This hyper-specific serotonin blockade makes it absolutely brilliant for refractory vomiting. It's heavily used in parvo, often teamed up with Maropitant for a real multimodal approach. It is also the undeniable drug of choice for vomiting caused by chemotherapy agents like doxorubicin, which trigger massive serotonin release, and for uremic vomiting secondary to acute kidney injury. But what about the contraindications? Well, a huge benefit of Ondansetron is that it is completely safe for GI obstructions because it has zero prokinetic effect. You do, however, need to dial back the dose in severe hepatic impairment and just use a bit of caution in herding breeds with known MDR1 gene mutations, though clinical toxicity there is pretty rare. As for availability, you've got veterinary-specific options like Pet Vomifix by Oraheel. But honestly, Ondansetron is widely used off-label from human medicine, so you'll frequently see brands like Emeset by Cipla, Ondan by Alkame, and Zofran. It's super versatile too, coming in injections, traditional tablets, orally disintegrating tablets, and even syrups. All right, on to Section 3, the prokinetic classic. Let's talk about Metoclopramide. This one is definitely an older tool, but it has a highly specific dual-action job. Centrally, at low doses, it acts as a dopamine or D2 receptor antagonist in the CRTZ, and at higher doses, it's a weak 5-HT3 antagonist. But the real magic happens peripherally. Metoclopramide is a prokinetic agent. It actually sensitizes the GI smooth muscle to acetylcholine. This means it actively restores normal downward GI motility by increasing gastric emptying and tightening up that lower esophageal sphincter, all without causing excess gastric secretions.
Because it literally pushes things downward, we reach for it when vomiting is secondary to delayed gastric emptying or postoperative ileus. It's fantastic for GERD and mild gastroenteritis, especially when given as a constant rate infusion. But listen up, because here's the most urgent warning of this entire explainer. Metoclopramide is strictly contraindicated in mechanical GI obstructions or perforations. Forcing gut motility against a physical block can literally cause the gut to rupture. No way do you want that. You must also avoid it in patients with seizure disorders, as it lowers the seizure threshold, patients with GI hemorrhage, and never use it at the same time as phenothiazines, because that drastically bumps up the risk of tremors and twitching.
For sourcing, veterinary-specific presentations include Paranorm injection in the 20 milliliter vial by Cipla or IPCA, and GB Norm. On the human side, you'll see smaller ampules of Paranorm and Reglan. It comes in injections, tablets, syrups, and, this is a great tip, drops. Those drops are exceptionally useful when you need absolute precision dosing in tiny kittens and puppies. Next up, Section 4, the older fallbacks, which brings us to the phenothiazines. We are specifically looking at chlorpromazine and prochlorperazine here. Now, these are vintage tools. They've largely been superseded by the newer drugs we just talked about, mostly due to their side effects. But they still absolutely have a place in your toolkit. So the crucial point is understanding their mechanism. They act centrally in the CRTZ and the vomiting center, but they cast a very wide net. They are dopamine D2, histamine H1, and alpha-2 adrenergic receptor antagonists. And it's exactly this broad receptor blockade that leads to their side effects. You might choose them for refractory motion sickness or intractable central vomiting, especially when newer drugs like Maropitant or Ondansetron just aren't available or are cost prohibitive for the client. But you must respect their contraindications. Because of that alpha adrenergic blockade, they cause profound vasodilation. If you give a phenothiazine to a hypovolemic or severely dehydrated patient, you will trigger severe, potentially life-threatening hypotension. They also cause significant sedation, so skip them if the patient has a history of seizures or an altered mental status. Birdies, you are almost exclusively going to be using human brands off-label. The two most common ones you'll run into are Stemetil, which is prochlorperazine, and Larjactil, which is chlorpromazine. Both are available in injections, tablets, and syrups. And finally, we arrive at Section 5. The Clinical Selection Quick Reference. This is your ultimate cheat sheet. Let's take all this pharmacology and apply it to some real-world clinical scenarios. And this brilliantly illustrates exactly how to make your clinical choices. Let's walk through it. Say you have a suspected GI obstruction. Your drugs of choice? Maropitant or Ondansetron. The rationale is simple. They control emesis centrally without stimulating gut motility. What do you strictly avoid? Metoclopramide, because, again, perforation risk. What about severe viral enteritis, like parvo? You want Maropitant plus Ondansetron. The rationale there is a multimodal blockade of both intense peripheral and central stimuli. You strictly avoid phenothiazines here because that patient is likely super dehydrated and you do not want to cause severe hypotension. For delayed gastric emptying, metoclopramide is your champion. Its prokinetic action restores that normal downward GI motility. And lastly, for motion sickness, Maropitant at a high oral dose is your specific choice to block those vestibular triggers via the NK1 receptors. So as we wrap up this explainer, I want to leave you with one final thought. Does understanding the why behind the vomiting reflex change your approach to the patient? Hopefully the answer is a resounding yes. By moving away from just blindly grabbing whatever antiemetic is handy and instead actively utilizing this clinical toolkit, you can replace guesswork with absolute precision medicine on your very next clinical case. Thanks so much for joining me on this explainer, and keep learning.